This section examines internal validity in epidemiological studies. Internal validity refers to the degree to which a study accurately measures the cause and effect relationship within the study population. The key question it asks is, does the study truly show that the exposure caused the outcome, or are there other explanations? Internal validity focuses on the scientific robustness of the study results and the accuracy of conclusions for the specific study population. Internal validity can be threatened by several factors. These include selection bias, information bias, confounding, small sample size, lack of precision, and lack of temporal order. Understanding these biases is crucial for evaluating the internal validity of epidemiological studies. Confounding is a particularly important threat to internal validity. A confounding variable is associated with both the exposure and the outcome, potentially creating a false appearance of causation. Construct validity is a component of internal validity that examines whether a study's measures accurately represent the concepts they're intended to measure. To summarize, internal validity measures the accuracy of cause-effect relationships within a study. It depends on proper study design and execution, can be threatened by various biases and confounding, forms the essential foundation for external validity, and is critical for drawing reliable conclusions. Understanding internal validity is crucial for evaluating the strength and reliability of epidemiological evidence. External validity, also known as generalizability, is a critical concept in epidemiological research. It refers to the extent to which the findings from a study can be applied to other populations, settings, and times beyond the specific group that was studied. Research studies typically examine only a small sample drawn from a larger population. External validity asks whether we can confidently apply the findings from this sample to the broader population. This includes other people, different settings, and even future time periods. When assessing external validity, researchers must consider whether the study participants are truly representative of the target population. Additionally, we must consider whether the results would differ in various clinical settings or contexts, and whether the findings will remain relevant as treatments and conditions evolve over time. Several factors can threaten external validity. These are conditions that limit how widely we can apply the study findings. Common threats include when a study population has unique characteristics that aren't found in other groups, when the study setting has specific conditions that can't be replicated elsewhere, or when the timing of the study uniquely influences the results. To summarize, external validity determines whether study results can be applied beyond the specific study population. It considers whether findings generalize across different populations, settings, and time periods. Understanding external validity is essential for properly translating research findings into clinical practice and public health interventions. Measurement validity is the first of the three pillars of validity in epidemiological studies. It assesses whether a test or instrument actually measures what it is designed to measure. Think of measurement validity like using a properly calibrated scale to weigh something accurately. The scale must be designed and calibrated to measure weight correctly. Let's consider an example. In a study measuring body weight, a good measurement would use a calibrated scale that accurately measures weight in kilograms. A poor measurement, lacking validity, would be simply asking people to guess their weight without using any measuring device. Measurement validity asks two important questions. Does our empirical measure observe what it purports to observe? And does the measure appropriately reflect the meaning of the concept being studied? Key aspects of measurement validity include comparison with gold standard methods, consistency of results across multiple measurements, and ensuring the measurement is appropriate for its intended purpose. Measurement validity forms one of the three essential pillars of validity in epidemiological research, alongside causal validity and external validity. Without valid measurements, even the most carefully designed study can produce misleading results. Ensuring measurement validity is a crucial first step in conducting trustworthy epidemiological research. External validity refers to the extent to which research findings can be generalized to other populations, settings, and times. Understanding external validity means asking if the findings of a study can be applied broadly. While internal validity asks if we measured what we intended to measure, external validity asks if these findings apply to other groups or settings. A key aspect of external validity is how well your research sample represents the broader population. When a sample closely represents the population, findings are more likely to be generalizable. Generalization is the process of extending research findings from your specific study to broader contexts. This process moves from specific results through discussion to broader conclusions. Multiple factors affect a study's external validity. These include sample characteristics, the study setting, historical context, intervention methods, outcome measures, and time-related effects. Let's compare examples of strong versus weak external validity. A study on diabetes treatment using diverse participants across multiple hospitals has strong external validity. In contrast, a lab study on stress using only college students from a single university has weaker external validity. To summarize, external validity is one of the three pillars of validity in epidemiological research. It concerns whether findings can be generalized to other populations and settings. Strong external validity depends on representative sampling and diverse study conditions and is essential for applying research findings to public health policy. In epidemiological research, bias represents a significant threat to the validity of study findings. Bias is defined as any systematic error in a study that leads to an incorrect estimate of the true effect. Unlike random error, which may balance out over time, bias systematically skews results in a particular direction, making findings unreliable. Understanding bias is crucial for several reasons. It ensures reliability of findings, helps in accurate interpretation of results, and is critical for evidence-based public health decisions. There are several types of bias in research. These include design bias, selection bias, procedural bias, reporting bias, and data collecting bias. A key distinction exists between biased and unbiased samples. Biased samples do not represent the entire population and may favor one position, while unbiased samples are representative and random. Bias can affect research validity in multiple ways. It can lead to overestimation or underestimation of effects, create incorrect associations between exposure and outcome, and result in misleading conclusions that impact public health decisions. Recognizing and addressing bias is essential for conducting reliable epidemiological research that can effectively inform public health policies and interventions. Selection bias occurs when the study population is not representative of the target population. This happens when certain individuals in the target population are more or less likely to be included in the study than others. Selection bias can lead to invalid conclusions about the relationship between exposure and outcome, as the observed association may not reflect the true relationship in the target population. The healthy worker effect is a common example of selection bias. Workers are generally healthier than the overall population, as those with serious illnesses are less likely to be employed. Loss to follow-up bias occurs when participants drop out of a study at different rates based on their exposure or outcome status. Volunteer bias happens when people who volunteer for studies differ from those who don't in ways that are relevant to the study outcomes. Selection bias distorts the observed relationship between exposure and outcome, leading to conclusions that don't reflect the true association in the target population. In epidemiological studies, the healthy worker effect is an important type of selection bias. The healthy worker effect occurs because people who are employed tend to be healthier than those who are unemployed or unable to work. Consider a study comparing health outcomes in textile factory workers to the general population. At first glance, this seems reasonable. However, this table shows how the healthy worker effect can skew results. Notice that workers have a lower mortality rate of 0.05 compared to non-workers at 0.25. The healthy worker effect introduces a systematic bias in our research. Our study population differs from the reference population in ways that affect our results. The core issue is that factory workers represent a selected group. To be employed in a factory, individuals must be healthy enough to work consistently. The consequence is that when we compare these factory workers to the general population, we might underestimate the true health risks associated with workplace exposures. Risk assessment tools like this may show lower risk levels than actually exist. Because the comparison group includes people who are too ill to work, the workplace risks appear artificially diminished. To address the healthy worker effect, researchers can compare with other working populations rather than the general population, use internal comparison groups within the same industry, or adjust for employment status and health factors in the analysis. Remember, the healthy worker effect is a crucial bias to consider in occupational epidemiology, as it can lead us to underestimate the true impact of workplace hazards. Information bias arises from systematic errors in how researchers collect data on either exposure or outcomes in epidemiological studies. Information bias can appear in various forms. The most common types include selection bias, detection bias, misclassification bias, and recall bias. Misclassification bias occurs when individuals are incorrectly assigned to the wrong exposure or outcome category. This can be non-differential, where the error occurs randomly across groups, or differential, where the error varies systematically between comparison groups. For instance, when studying the health effects of smoking, relying on self-reported smoking status can introduce misclassification bias. Some smokers may report being non-smokers due to social desirability, leading to incorrect conclusions about smoking's health impacts. Recall bias is a type of information bias where cases, people with the disease, and controls, people without the disease, differ in how accurately they remember and report past exposures. Cases often scrutinize their past more thoroughly, searching for potential causes of their condition. Information bias is one of three major categories of bias in epidemiological studies, alongside selection bias and confounding. Each of these can significantly distort study results and lead to incorrect conclusions. In modern data science and machine learning applications, information bias manifests in various forms, including measurement bias, sample bias, and algorithm bias. These can perpetuate existing biases in the data, affecting the quality and fairness of automated decisions. Information bias can significantly impact study results by leading to over- or underestimation of associations between exposures and outcomes. It directly affects the internal validity of a study and can be particularly challenging to detect and quantify. Researchers must carefully design their data collection methods to minimize these systematic errors. In summary, information bias arises from systematic errors in how researchers collect data on exposures or outcomes. Being aware of its various forms, such as misclassification and recall bias, is essential for designing rigorous epidemiological studies and properly interpreting their results. Recall bias is a type of information bias where participants with a condition remember and report exposures differently than those without the condition. This is particularly problematic in epidemiological studies, as it can distort our understanding of the relationship between exposures and outcomes. Case control studies, which compare people with a condition to those without it, are particularly susceptible to recall bias. For example, in studies investigating congenital malformations, mothers of babies with birth defects may recall prenatal infections differently than mothers of healthy babies. Let's examine a specific vignette. In a study of birth defects, researchers compare mothers of babies with congenital abnormalities to mothers of healthy babies. Mothers of babies with defects have likely spent considerable time thinking about what might have caused their child's condition, making them more likely to recall exposures like medications, infections, or environmental factors during pregnancy. This difference in recall is influenced by memory processes. Memory is subjective and prone to distortion, especially when emotions are involved. To mitigate recall bias, researchers employ several strategies, including using standardized questionnaires, collecting exposure data from medical records, blinding interviewers, and matching cases and controls on key variables. In epidemiological studies, confounding is a critical concept that can substantially impact research validity. Confounding occurs when a third variable, known as a confounder, distorts the relationship between an exposure and an outcome. For a variable to be considered a confounder, it must have three key characteristics. First, it must be associated with the exposure. Second, it must be independently associated with the outcome. And third, it cannot be on the causal pathway between exposure and outcome. This diagram illustrates how a confounder affects the relationship between exposure and outcome. The confounder causes both the exposure and the outcome, creating a distorted association if not properly controlled for. It's important to distinguish between confounders and mediators. A mediator is on the causal pathway, where exposure causes the mediator, which then causes the outcome. In contrast, a confounder is not on the causal pathway. Instead, it independently causes both the exposure and the outcome, creating a false association between them. A classic example of confounding is the historical association between coffee drinking and lung cancer. Early studies found that coffee drinkers had higher rates of lung cancer, suggesting coffee might cause cancer. However, smoking was the true confounder. Smokers tended to drink more coffee, and smoking causes lung cancer. Once researchers controlled for smoking, they found no significant association between coffee and lung cancer. This demonstrates how confounding can lead to incorrect conclusions if not properly addressed. To summarize, confounding is a critical concept in epidemiology that can create false associations or mask true ones. Confounders must be controlled for in either the study design or analysis phase to ensure valid results. It's essential to identify potential confounders before conducting research to properly address them. Remember that confounders are different from mediators, which are part of the causal pathway between exposure and outcome. In this real-world vignette, we'll examine a classic example of confounding. Imagine researchers are conducting a study examining the relationship between coffee consumption and heart disease. Initial data analysis suggests there might be a correlation between coffee consumption and increased heart rate, which could be related to heart disease risk. But there's a problem: confounding. A confounder is a variable that influences both the exposure and the outcome, creating a false or distorted association. In this diagram, we can see how a confounder affects both the exposure and outcome variable, creating a distorted association when not properly controlled for. In our coffee study, the confounder is smoking. People who smoke tend to drink more coffee, and smoking is a known risk factor for heart disease. This diagram shows how smoking can lead to both increased coffee consumption and cancer. The same principle applies with heart disease. Let's consider the implications of this confounding. Without controlling for smoking, coffee consumption appears to be associated with heart disease. However, after properly controlling for smoking in the analysis, this association may weaken or completely disappear. This example highlights the critical importance of identifying potential confounders in epidemiological studies to avoid drawing incorrect conclusions. After controlling for smoking, we can see the true relationship. Smoking increases coffee consumption and also causes heart disease, while coffee itself may have minimal or no direct relationship with heart disease. Matching is a powerful strategy used in epidemiological studies to control for confounding variables. The primary purpose of matching is to control for known confounding variables by creating comparable groups at baseline. This reduces variability between groups and strengthens the internal validity of a study. Here's an example of matching in action. Participants are paired based on similar IQ scores before being randomly assigned to either an experimental or control group. This ensures that intelligence levels are equally distributed between groups. There are two main types of matching used in epidemiological studies. Individual matching creates one-to-one pairs based on specific characteristics like age or sex. Frequency matching ensures that groups have a similar overall distribution of characteristics rather than exact pairs. Matching can be applied in different study designs. In case control studies, controls are matched to cases based on potential confounders. In cohort studies, exposed and unexposed groups are matched on baseline characteristics. While randomization distributes known and unknown confounders by chance, matching specifically controls for known confounding variables. These approaches can be complementary in study design. Despite its benefits, matching comes with several challenges. It can be difficult to find exact matches, which may limit sample size. Researchers must have advanced knowledge of important confounders, and statistical analysis must properly account for the matching process. Case control studies frequently employ matching to ensure that cases and controls have similar characteristics. Here, participants are grouped based on their exposure status and then further categorized as cases or controls, depending on whether they develop the condition of interest. In summary, matching is an effective strategy to control for known confounders in both observational and experimental studies. It can be combined with randomization for stronger designs, but requires careful planning and appropriate statistical analysis to be effective. Stratification is a powerful analytic adjustment technique used to control for confounding in epidemiological studies. At its core, stratification involves analyzing the association between an exposure and outcome within different subgroups of a confounding variable. Let's consider an example. Does coffee consumption increase the risk of heart disease? This relationship might be confounded by smoking, since smokers tend to drink more coffee, and smoking causes heart disease. Stratification provides a solution to this confounding problem. First, we divide our study population into subgroups based on the confounding variable. Then, we analyze the relationship between exposure and outcomes separately within each stratum. Here we see how stratification works in practice. By dividing our population based on a confounder like income, we can compare treatment and control groups within each income stratum. This allows us to isolate the true effect of our treatment. Stratification can also be used in the sampling process. By ensuring representation from all important subgroups, we can better analyze how effects might differ across these groups. Stratification offers several benefits. It effectively controls for known confounders, can reveal effect modification across different strata, and is relatively simple to implement. However, it does have limitations. It requires adequate sample size in each stratum, cannot control for unknown confounders, and becomes unwieldy with multiple stratification variables. When properly applied in epidemiological studies, stratification helps researchers isolate the true effect of an exposure on an outcome by controlling for confounding variables that might otherwise distort the results. Before implementing bias reduction strategies, epidemiological studies often suffer from significant limitations. Results are skewed and unreliable, leading to false associations and hiding true effects. This makes study conclusions potentially misleading. To improve study validity, researchers employ various bias reduction strategies. These include randomization, standardized questionnaires, matching, blinding, stratification, and multivariable regression. After applying these strategies, study results become significantly more accurate and reliable. The data better reflects true relationships between variables. Conclusions are more trustworthy and provide stronger evidence for public health decisions. Comparing results before and after bias reduction clearly demonstrates the importance of these methodological strategies. By implementing proper study design, data collection methods, and statistical techniques, researchers can produce more accurate and trustworthy evidence for public health decision-making. Section 23. The importance of recognizing and mitigating biases in epidemiological research. Understanding the different types of biases is the first step in recognizing them. The World Health Organization classifies biases into selection bias and information bias, each with their own subtypes. Biases don't just affect data collection, they influence how we interpret evidence. Confirmation bias, for example, leads researchers to favor information that confirms their existing beliefs while dismissing contradictory evidence. When biases go unrecognized, they can significantly distort research findings, leading to incorrect conclusions that might inform public health decisions. Biased research can lead to flawed public health policies. Healthcare policies, including patient care, drug, staffing, and safety regulations, should be based on methodologically sound research. When policies are based on biased research, this can lead to ineffective interventions, wasted resources, and potentially even harm to populations. Mitigating biases requires a collaborative approach. Research teams must implement rigorous methodologies and quality control measures throughout their studies. Effective bias mitigation includes implementing proper study design, ensuring transparent reporting of methods and results, rigorous peer review, appropriate statistical adjustments, and replication studies to confirm findings. When biases are properly recognized and mitigated, the resulting evidence can be trusted for making critical public health decisions. This ensures that interventions and policies are based on sound scientific findings. The benefits of bias-conscious research include maintaining scientific integrity, ensuring patient safety, optimizing resource allocation, and preserving public trust in scientific evidence. In summary, recognizing and mitigating biases is not just good scientific practice. It's essential for generating the trustworthy evidence needed to protect and improve public health. In our final section, we conclude by examining how to ensure trustworthy public health evidence. The quality of public health decisions depends directly on the validity and reliability of the epidemiological evidence that informs them. Throughout this course, we've explored various types of biases in epidemiological research, including selection bias, information bias, and confounding. Understanding these concepts is crucial for implementing the evidence-based public health framework that guides effective interventions and policies. By focusing on strong validity, minimizing bias, and implementing effective research strategies, we create a pathway toward better public health outcomes. As epidemiologists and public health practitioners, we must recognize potential sources of bias, design studies to maximize validity, apply appropriate analytical methods, and report our findings with complete transparency. Ultimately, our goal is clear. Trustworthy public health evidence leads to effective interventions and healthier communities for all.